Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We have a great opportunity to have a terrific speaker, Dr. Harvey Richman, who's a graduate of the New England College of Optometry. He has achieved credentials as a fellow of the College of Optometrists and Vision Development, as well as a fellow of the American Academy of Optometry. He also is one of the first diplomates of the American Board of Optometry. In 2007, he was awarded the Optometrist of the Year in New Jersey. He has been president of the New Jersey Society of Optometric Physicians. And most recently, and this is really highly significant, he was recognized with the New Jersey Society of Optometric Physicians Lifetime Achievement Award. He also is a standard field sobriety test certified, and he works and helps police officers on understand the effects of alcohol, cannabis, and vision. So with that, please, a nice virtual, warm OEC welcome to Dr. Harvey Richman. Harvey, you can take it away.
You got it. Thanks, Joe. I appreciate the welcome, and always good to see Greg and you at events like this. So again, today, the course explains itself. The title explains itself, so you'll be able to do that. Hopefully everybody will get a chance to take a look at the deck later, be able to go back and review anything. There may be a couple of changes on some of the slides from the deck that was submitted for your review. If you have any questions afterwards, like Greg or Joe said, reach out to them. They can forward it over to me, and I'll be happy to make any clarifications for you. Alrighty. There we go. Okay, so basically all information the time I've given you is current. I have been a consultant for Neuralens, Right Eye, Zeiss, Barty EMR over the past 24 months. There is no conflicts of interest in this event at this point. What we're going to cover, basically the top 20 drug classes, their uses, common side effects, ocular side effects. Now we'll do some clinical care guidelines for monitoring them as we go along also. So as you guys are probably aware, there's a lot of different medications out there. We're going to be talking about, obviously, this is all systemic management. But the top 20 medications, lisinopril, levothyroxine, Lipitor, you can see the list that's up there. These are ones that you're going to see pretty much every single day when you're seeing your patients. You're asking your patients, what are their medications? It's gotten to the point where somebody will actually say, I'm taking a blood pressure medicine, and I just, automatically just, and they say it starts with an L. So it's lisinopril or losartan. It's automatic at this point. It starts with an A. It's amlodipine. And it's funny when they'll argue with you when you say, well, you're on Norvasc, and they say, no, I'm on amlodipine. Okay, fine. Whatever you wanted to call it is perfectly fine. At this point, 55% of Americans take one or more medication. Now, I think we're going to do poll number one.
The poll is open, and it is, what is the number one drug class in the U.S.? Diabetic medications, ACE inhibitors, lipid regulators, or hormonal contraceptives?
So again, it's interesting. Many of these are also vary regionally, but we're talking across the country. What is the biggest one? Obviously, certain states are going to have higher incidence of diabetes. Hypertension is pretty broad across the country, but there are certain areas that are going to have a little higher incidence. And as it turns out, the certain states that have diabetes have higher incidences of cholesterol as well as hypertension. So got to take a look at those options there.
So at this point, I'm sure there's no questions. So the polling, it looks like it's pretty good in here. I think the trend line is set, so I'm going to display it. And Harvey, glad you did it. We got a pretty close one here. Diabetic medications at 34, lipid regulators at 42, ACE inhibitors 15, and the hormones are at 9%. So going down the line here, 34, 15, 43, and 8%.
I'm pretty impressed because unless people were looking at the slide deck, I really would not have thought that the lipid regulators was the highest one. The honest one that I thought was going to be the highest was going to be the anti-anxiety medications, but they're not listed. That was not one of my 4 choices. But that being said, the top 20 drug classes, lipid regulators are the highest. Antidepressants, there you go. Those are your second one. I seem to have, maybe it's because we're in the Northeast and things like that, we seem to have an awful lot more patients on the antidepressants and anti-anxiety medications. Number 3, narcotics, still blew me away that it's still the 3rd highest drug class being prescribed at this point. I would have figured that would have dropped down a bunch, but it's still, there's still a lot of doctors out there using them, even if it's for short term. I think that we're not seeing as much overuse, but there's still a fair amount of use out there. So I just want to kind of go down those. You can look at the slides later, but just want to have you have an idea what these are. And what we're going to do today is we're going to go over all 20 of these classes is the goal before we're all done. Oh, look at that. We got another question already.
All right. Here we go. What is the most common documented ocular side effect of systemic drugs?
Again, the choices here are dry eye, pupillary abnormalities, blurred vision, and conjunctival redness.
So I have blurred vision and pupillary abnormalities flip-flop. So I'll have to read you the answer. I have
I
dry eye,
apologize.
blurred vision, and pupillary. So when they come in, I'll let you know. So they're
Okay.
coming in nice.
Sorry.
That's not sorry. It's no big deal. Just when I give you the numbers, I want to make sure that you and I are on the same page. All good. All right, people are responding quickly here. I'll display the answer. We have 63% going with dry eye. We have blurred vision at 33, pupil abnormality is 1%, and conjunctival redness is 2%.
All right, well, we're going to jump ahead. Well, guess what? You guys were taking the idea similar to what I was thinking, which was that dry eye is going to be the number 1 aspect. Now, dry eye is the biggest complaint, but it is actually, when you look at the studies, pupillary size abnormalities was the actual number 1 side effect. And that's when they look at the clinical studies that go along to see what's happening there. There was, either mydriasis or myosis was occurring on the vast majority of these. When we live in our world, dry eyes are a big factor. Why is this important? Well, because when we do things, and Joe made reference to some of my background in the police departments, and that is that we as optometrists do not the best evaluation of pupillary size, but it could be majorly important for checking for side effects of systemic diseases. So just be aware of those things on there. All right, so let's talk about number 1. The number 1 drug class, as we talked about, was lipid regulators. So basically, these are your statins. This is the primary group, the statins, your Lipitor, Zocor. Now, I have the number 3 and number 5 up there because that was number 3 on number 5 on the top 20 drugs that are out there. You also have your fibrates such as Tricor, Triliptics, things like that. These are used for cholesterol reduction, triglyceride reduction, basically helping reduce coronary artery disease. What are the side effects, the systemic side effects? Again, these are things that you're going to be taking a look at. We hopefully are not going to see an awful lot of these because most of these patients are being managed pretty good. The biggest one that we hear of is the myopathy, the patients that have the muscle aches, the pains along those lines. But you can also see some patients with peripheral neuropathies on these. And it's important because you talked about seeing older patients and they're going to be putting their drops in and they may not be able to use they may not be able to squeeze the bottles as well, especially on the smaller ones like the preservative-free drops, because they just can't hold the vials as well. Steven Johnson is kind of our picture here. We got to be aware of those things. We are not prescribing these, but just want you to be aware of it. Now let's go over to the ocular ones. So we're going to talk about a multitude of ocular side effects throughout all of these, but on the lipid regulators, cataracts is a question. We'll talk about those as we look at that. Blurred vision, diplopia, ophthalmoplegia. I've never seen ophthalmoplegia associated with this, but it's another recorded aspect there. And again, ocular hemorrhages. There was a study, and it showed that there were a small percentage of patients, 2% of patients that have ocular effects associated with taking a statin. That being said, when we look at the studies a little bit deeper, it shows that statin uses that for the patients that are in their 50s and 60s, at least 5 years may be protective against cataract development. But there was no protective effect over 65. Well, I mean, it's kind of an interesting, how do you figure these cases out when you really don't have too many patients that are over that are under 65 that are having cataracts. So that protective factor there, I'm just not necessarily sure where they come up with this, but those are studies that they work on there. But it did say there was an increase in incidence of cataract surgery in old and young with greater than, or excuse me, with less than 5 years of use of statins. Another study showed that statins used continuously for 2 years showed a 21% reduced risk of glaucoma versus non-users. Again, these are studies that are out there. So what does this mean? This means that, you do need to be aware of the utilization of these medications. We think about diabetes medicines, steroids, and how they have impact on cataracts and glaucoma. But now we also have to think about how the lipid regulators are going to be doing it. And that's when we have these patients that are taking all these statins. And everybody's on a atorvastatin or simvastatin or rosuvastatin, whatever the medications is out there. So when you're seeing these patients, if they are not on one of these medicines, and you're seeing changes of glaucoma, well, maybe you need to talk to them and consider whether or not that's something you want to add to the options for the cardiologist. So there was 2 different studies that we looked at here. One basically looked at 14 studies and showed no significant association between statin use and AMD. There was another study that looked for and found that with early AMD, there was a 17% reduction in risk with statin use. That's a pretty significant number. And it showed that statins were had a protective effect for wet AMD. No association for statins versus geographic. Well, again, it shows that there's a high likelihood. And again, this makes lots of sense when you think about where AMD comes from lack of, for deterioration and lack of blood supply to the RPE and those types of areas, that if you're not getting a good blood supply there, the tissue is going to die. So using these makes the blood flow better, makes the patients have less likely for macular degeneration. So what about the clinical care guidelines? So again, statins may provide, and I use the word may, provide protection for glaucoma. There are greater studies that are going on in that. They may or not provide protection for cataracts. The literature was questionable, as I showed there. And statins may impact the progression of macular degeneration. Pay attention to those. One of the things that you do need to worry about, or not worry about, pay attention to, and I think I'll talk about a patient a little bit here too, but use of macrolides, such as erythromycin, can increase the risk of myopathy when used in combination. And it can include these ocular muscle myopathies, which we were talking about the ophthalmoplegia before. I've never seen those. I had a patient, the reason I wanted to bring this up though, is I had a patient today who came in, and he walks in, he says, "Doc, I have blepharitis." I take a look at him and he's got terrible eczema all along his forehead, his eyebrows, things like this. He said, I said to him, "Look, you don't have blepharitis. You got something else going on here." We started talking about it, and it came back to, I had to just do some quick Googling and found a combination of some of his medications he was taking actually caused his eczema. It was a documented component here. So he had already had an appointment with the dermatologist, says, "No, you know what, you need to go back to your PCP. And these are, we have to look at." Why do I bring this up? Again, combination of these medications can cause different effects for your patients, and you need to be aware of what those are when you're dealing with them. They talk about systemic cyclosporin. We already know about this, that it has an impact on the health, but we now also have to pay attention that it is linked for bioavailability of a Lipitor or atorvastatin, but no mention with the issue of topical cyclosporin. They've never done any studies on those. So it's really, it's in there as just a conversation point. Number 2, antidepressants. Okay. So these are your serotonin reuptake blockers, SSRIs, SNRIs, different things like that. Zoloft, Prozac, those are the big ones that are out there at this point. Again, you're going to know them as sertraline and fluoxetine, as you may see those. And then your MAOA inhibitors, Zolpar, Parnate. Then those are, again, not as common to be used, but you still see the patients out there because the MAOA inhibitors give other side effects that you need to be aware of. And then your tricyclics, your Elavil, Pamelor, those I see more on my group home patients. I don't know if it's because they are just more and more advanced, but I do see a fair number of the tricyclics still going around at this point. So we already said that sertraline and fluoxetine are in the top 20 drugs. It's used for depression, anxiety, OCD, PTSD, things along those lines. It can be used in combination with bipolar disease or resistant depression. So again, you'll see these. I brought up the fact that up in the Northeast, there seems to be in the trend to see an awful lot more of this up in the Northeast. And I don't know if it's just the stress of living up here, but that's what they deal with. Side effects, again, nausea, dizziness, sleep disturbance. Brings in Stephen Johnson again. Luckily, I have, unluckily, I've seen my fair share of Stephen Johnson. I've never seen one from an antidepressant, but it's documented that it can be out there at this point. The suicidal thoughts. Be careful if you see these patients on there. One of the things we do, one of the other discussions that I often talk about is MIPS and the, Medicare incentive programs, is talking about, oh my gosh, I forgot the word for it now. Societal, give me a hand on Joe.
Suicidal ideology?
No, not suicidal, but it has to do, I'll come up with it. Social something or other, and I just totally forgot what it is. But asking patients about how they feel and how they're living and things along those lines. Social determinants of health. Thank you very much. Good job, Joe. I appreciate that one. So the aspect is looking at these things and asking patients if they're on these antidepressants. We're going to talk about other conditions in a little bit to talk about depression and how they have an impact on the visual system. So antidepressants, as far as the ocular side effects, mydriasis. We talked before about paying attention to pupils. You will see these patients, if they are taking excessive amounts or higher dosage, that they do have mydriatic effects on their vision, which will also impact their blurred vision at near specifically. So these kids that, the younger people that are having accommodative dysfunctions, they blurry on the computer, we're all thinking, oh my gosh, this is dry eye. Well, guess what? It very well may be the antidepressant that this person is on. There's increased risk for angle closure, glaucoma. We'll show those in a little bit. And that has to do with, again, the mydriasis at that point. Other ones that we do see again is photosensitivity, just things that we'll have to pay attention to. So dry eye mechanism. So one of the components that we think about with the antidepressants is it does caused by a parasympathetic denervation of the lacrimal gland. Okay, it just reduces the whole process. It actually does cause a release of serotonin, and it will also therefore change the lacrimal secretion. We do know that there's a chronic exposure to histamine, and serotonin will alter that secretory process. So again, these are different concepts as far as how the antidepressants are going to have an impact on it and why they do cause dry eye, which goes back to everybody else's first question, why we think these people the biggest side effect is dry eye. Because when we're in our office, that's what patients come in and complain of. And what do we say? Okay, well, it's probably your medicine. Impact on corneal sensitivity leading to dry eye symptoms. Again, these are just components that are there. There are concerns sometimes with with optic neuropathy coming from these just because of the ischemic aspects of the medication, the transient vasospasms that occur from the medications, and then visual hallucinations are due to cholinergic hyperactivity. You should be able to pay attention to these. Remember again that we're going beyond just being eye doctors. We're going to be doctors. We talked before about this closed angle glaucoma. With antidepressants, it is a mydriatic component. How much of an impact is it? You may get a millimeter, but you got to think about a millimeter to 2 millimeters of opening on a patient who has a narrow angle already is going to cause potentially an increase in pressure, may cause a closing of that angle, or at least a narrowing of the angle. Let's put it that way. But you need to be aware of these components there. So if you're on if a patient is on antidepressant and you started to see an increase in IOP, throw that gonio lens on there. Double check those things because there's definitely a consideration that you may be able to see. You're probably not going to pick up a 1 to 2 millimeter pupillary difference. You're not going to see the person who's going to go from a 5 to a 6 millimeter pupil, but you may see enough of it. It's going to change those angles. So again, looking at these other components here, let me just move this over here. I apologize. Serotonin, no, SSR, serotonin plays a significant role in ocular tissue. So we said that. So higher serotonin levels linked to IOP. It causes it to be increased. Serotonin is linked to visual processing. So again, as you start to feel better, you're going to make some changes there. If you start to reduce those, your processing is going to reduce also. There are some studies that show serotonin may impact RPE function. But the primary one is looking for angle closure is the most significant issue here. Antidepressants. This is actually part of a neuropharmacology study that came out. Basically says in presence of certain glaucomatous risk factors, sex, race, positive family history, whatever, it is ethical to submit the patient for an ophthalmologic consultation before the starting of the SSR treatment. Now, you know what? That's their recommendations. That being said, you know, how many times have you ever, I mean, and I can tell you zero, you know, how often do you get patients being referred in for glaucoma evaluation before starting on these medications? I have them being referred in for the steroid inhalants, which we'll talk about a little bit, and obviously for the methotrexate and the hydroxychloroquine patients that they want to get the baselines on them. But I've never had one be referred in for an antidepressant. So again, this is their guidelines. That being said, you know, not too many things are being, you know, not everybody's following guidelines. What do we recommend? Recommend yearly comprehensive exams. You know, look for blurred vision, look for anatomically narrow angles, because that's the biggest one to pay attention to. And then treat the dry eye. We already said that these conditions, these medications do have an impact on dry eye. Number 3 is our narcotics. So oxycodone, hydrocodone, again, they're, you know, for most of the optometrists in the country, hydrocodone is still a usable medication in the classes. Some states, they can still do full class 2s. The combination of acetaminophen, hydrocodone, or Tylenol number 3 or 2, whatever we're going to be using at this point, in those scenarios, that is still the number 9 prescribed medication at this point, and it's used for pain management. The possible side effects, addiction, you know, it's a consideration. The bigger ones, the GI issues, I think are the biggest ones on there, the vomiting, the diarrhea, and long-term use is constipation. So it's funny how the GI issues are so impacted at this point. Drowsiness, yes. You know, I've had many a time where we're talking to patients and, you know, they're just falling asleep in the chair. You know, my first thought is they're on cannabis or something along those lines, or they've got other medical conditions. But then, you know, when we start to talk, well, yeah, you know, I'm taking pain pills for my back, but I didn't want to tell you because I was embarrassed. You know, well, you need to pay attention to those. What are you going to pick up? Diplopia is on here, but you obviously know that on narcotics, the primary one is going to be the pinpoint pupils. You know, I've had, unfortunately, again, my fair share. I live in an area where opiate abuse is pretty regular, and I use the word abuse and regular in the same phrase there. And sometimes I have to worry, are these patients that are coming in with the pinpoint pupils, are they from narcotics, or are they from, you know, is their diabetes just completely out of control, which we'll see that being another component there. But with those patients, you'll get the accommodated dysfunctions. You'll see nystagmus also on these patients. So this is part of the stuff that we teach the cops to be looking for when they're doing their evaluations. So I want to make sure that you're at least paying attention. What are you going to pick up? Again, the primary one is going to be pinpoint pupils. You may notice some other eye movement dysfunctions and accommodative dysfunctions. The IV abusers are more susceptible to viral hepatitis, but I'm going to show here that it says one study found that there was developed endogenous fungal endophthalmitis without systemic symptoms. The patients, you know, the symptoms ranged from 2025 to hand motion, went really bad really quickly. But there was this outbreak. And again, that goes back, that was 8 years ago. It was an older study, but I thought that it was something to pay attention to, because you may find that you're getting an endophthalmitis. You have no idea why. Odds are that they're going to walk into your office and it's going to be like a red eye, and you're going to take a look at it and you go, oh my God, there's some type of uveitis. You're going to probably refer off to the retinal specialist or work with somebody in your office who works on retina. But that person is going to have to be fully worked up, because short of any other components there, you need to find out, are they using IV drugs at that point? So on codeine, the effect of the visual motor coordination was limited, but it is dose related and linear. So again, the more drug that you use, the bigger the impact on visual acuity. And when they refer to dynamic visual acuity, that's the one when the patient is looking straight ahead and the target's moving, or vice versa. The person's head is moving, the target's staying still. And they looked at it and found out that those patients just cannot control their eyes as well as they are, or as well as they should. That's extremely important for driving, obviously, because things are moving as their eyes are trying to look straight ahead. There were some studies that showed that utilization of intravenous or topical opioid administration can reduce IOPs. IM morphine decreases eye pressure also. Patients addicted to heroin often have a lower IOP than controls. And then the IOP goes back up with the naloxone. Is a lower IOP a way to detect systemic opioid abuse? Well, I mean, again, the question comes in, and this is what we're talking about pupils, is whether or not you're going to be able to see these patients over the course of years. Because if they're running consistently at 19, 18, 19, 18, and then all of a sudden they start coming in with smaller pupils and they have pressures of 13 and 14, then you got to start thinking about it. But just having a patient who has a pressure of 12 or 13, you can't make a decision on the first time visit. Okay. Even with the small pupils, you have to kind of have a couple ideas to look at there. Yeah, there's some other studies that are out there that basically talk about the fact that there's suggestion for utilization for regulation of iris function, aqueous humor dynamics. At this point, it's still being researched. So what do we need to do? Monitor for unexplained diplopia. The diplopia that we've seen is primarily like a convergence insufficiency, and that's it's a nearest aspect. Monitor for unexplained blurred vision. Again, accommodative issues are the primary ones you're going to look for there. Be alert for the signs of the opioid abuse, the lower IOPs, the small pupils. And then, if you feel comfortable, you can obviously talk to the patient and then to the primary care physician or the pain management person about other alternatives. If you see that there's some type of ocular effect from the opioids, I guarantee you that they're on too much at that point. If you can see it, there's too much in the system. Number 4, beta blockers. Okay, so beta-1 selective, cardioselective beta blockers impact hormone epinephrine, and it slows down the pulse, lowers blood pressure. We understand that. The 4 primary ones that are up there are atenolol, propranolol, metoprolol, and carvedilol. Set number 8 is toprol, and number 17, again, these are the top 20 medications. And it's used for hypertension, but it is often not the primary medication. It's often used in conjunction, or you may see these with AFib and other components there where they're trying to get some management that way. What are the side effects? The number one is fatigue. I mean, years ago, I took Inderol for migraines. And the biggest issue is I couldn't get out of bed. It just was knocking me on my ass at that point. But you will get some other side issues with shortness of breath, as we're aware of. And this is stuff that we think about with our topicals. High levels of topicals can cause some of these issues also. The problem is exacerbated, or it's increased, obviously, when you are doing a systemic because of the volume that's being put in there and the way it's being absorbed. Now, non-vasodilating beta blockers do have an increase in glycemic and lipidic control. Your blood sugar is going to go up and your cholesterol levels are going to go up. What are your non-vasodilating ones? Your atenolol, metoprolol, and propranolol. That being said, that they say that the carvedilol, Coreg, labetalol, those types of medications there are going to have more favorable effects on glucose. So if a patient, again, we have to assume, and you know what happens when you assume things. We have to assume that the cardiologist is working with the endocrinologist, or the primary care doctor is paying attention to all the other medications that are out there. There's many times that I'll see that a patient, their A1C is out of whack, and now all of a sudden they're taking metformin, or they're taking Wegovy, or whatever it is, and it's because their doctor is trying to control their heart, and they're just changing the one medication and not paying attention to their other aspects. And by simply changing the medication, the beta blocker, if that's what the cardiologist wants, or the primary care doctor wants, they theoretically are changing the way that this person's blood sugars are picking up. So again, just another thing to pay attention to, that you have the ability as a physician to work with other doctors along the way. So what are we going to look at for on our end of the beta blockers? Blurred vision, pupillary size, again, going to dilate them slightly. Ptosis, I have seen patients, again, basically it's just a fatigue factor on my end, but it's almost like a bilateral ptosis as opposed to anything else. Diplopia, again, it's because of just the reducing in accommodative issues. They have greater convergence insufficiency that way. Dry eye, it reduces tear lysozyme levels. It definitely creates that component that you're going to just have more dry eye with those patients. Okay, so there was a study, and this is interesting because I talked, I have a, you know, I've been out for well over 30 years. And I have a doctor that's out now about 15 years, and we have another doctor that's been out for less than a year in our office. Um, and it's funny the conversations that we have, what we learned years ago versus what we learned 10, 15 years ago versus what we learn now. Um, and there was a study that showed that patients on systemic beta blockers had lower IOP readings. And I've actually had the docs in the office, the I'll use the word middle-aged doc, the one who's in her 40s, who specifically, won't treat a patient with because for a specific medication because they're on a beta blocker and they think that that's going to cause a lower IOP and they think they have low tension glaucoma. It basically, why am I bringing this up is there was another study that came afterwards and basically said had no impact or negligible impact on IOP in the long term. So, do you need to pay attention to this? Yes. Do you think that utilization of a systemic beta blocker is going to really lower the IOP? Maybe. I'll give them the maybe. I won't say a definite yes on that aspect of it. And, do I suggest that the patient on a systemic that I would put on a topical? No, I would not, because there are going to be some systemic side effects from the topical, with the best of our ability to do punctal occlusion and telling our patients not to, to blink and get all this other stuff to stop them in there. There's still going to be some systemic involvement, so we try to avoid utilizing them. But I don't make the utilization of a beta blocker as making a decision that the pressures are lower just because they're on a beta blocker. That's kind of where my point on this one. Clinical care, or basically pay attention that beta blockers can interact with antihistamine and prostaglandin synthase, such as indomethacin. So that if you're on a patient, it's you have a patient that's using beta blockers, it can be changed by these other medicines. So just be aware of those. Treat the dry eye patients that see with these that are on an oral beta blocker. They are going to be drier. There's no question on that. And you'll have to turn in probably next month for a dry eye lecture from OEM at that point. I'm not going to get into that. Consider beta blockers when used when evaluating for glaucoma. It says it could be lower, but again, clinically, I don't. I look at the studies and I say, okay, you know what? There was a study out there and the people started talking an awful lot about it, but we kind of pushed it off to the side for me. Number 5, moving pretty good. The ACE inhibitors. Number 1, yay, lisinopril. That was the first one. That was the top medication that's out there. Number 1 used medicine in the country at this point. But you still see other ones that are out there, Lotensin, Vasotec, Altase. I don't see Ramipril as much anymore. I used to see a fair amount of it, but it's kind of reduced at this point. Lisinopril is still a biggie at this point. Again, hypertension, coronary artery disease, things along those lines. And actually, we have seen them for migraine patients also. We see a lot of headache patients, so we see patients on a lot of the ACE inhibitors for these things. Makes tons of sense. ACE inhibitors relaxes the blood vessels by blocking the angiotensin converting enzyme. What it does is that allows the blood vessels, angiotensin 2 narrows the blood vessels. So if you're inhibiting that, it's going to open the vessels, and allows the blood supply to go through the vessels easier. And that's the purpose of it. By narrowing, it can cause the high blood pressure, forcing the heart to work harder. But by opening it, it's going to make the heart not have to work as hard. It's going to let the blood supply quicker. What are the side effects on these? Dizziness, cough is a big one. It's only listed as number 2 on this list, on this slide, but I've seen a fair number of patients, again, that they're taking specifically, enalapril was the one that I saw a lot of, where the patients were just getting this cough, and they ended up having to get off the medication for it. The angioedema, again, I'm just trying to think of things that I've seen over the course of my years of working with these patients. I have seen a couple cases where patients were having some side effects that way. Just be aware of these. These are things you're going to pay attention to. And it's fun. To me, it's fun to try and see when a patient comes in with the systemic side effects of something, or they're telling me they're dizzy or these things, and trying to figure out whether or not it is the medication or it's the TBI that they've come in with, or whatever it may be, trying to figure out what the factors are here. So, the ACE inhibitors, the possible ocular side effects, vision loss. Okay, it is a consideration there. We're going to talk about any of these medications that are dealing with hypertension. They have side effects associated with vision loss, but the condition that they're treating is also a risk factor for vision loss. We'll talk, diabetes, the other hypertensive medicines, they can cause there. Diplopia, again, that's a recorded one. I haven't seen too much. Photophobia, yeah. And the photophobia on these is not like the dry eye photophobias. These are patients that seem to be, in my experience, seem to be the ones that are also like, and I used the term before, the TBI patients that are sensitive to fluorescent lights, more so than just the bright lights at that point. Retinal hemorrhages due to anemia, and then the angioedema, lids and orbits. These patients get these big puffy eyelids. There was, again, a couple studies. Dry AMD is, it makes a statement, is not a retinal vascular pathology, but they did see that the utilization of these ACE inhibitors actually was beneficial for prevention of AMD. They were looking at this, and they were looking for diabetic retinopathy. The evidence showing clear contribution of angio-2 to the development of disease is out there. Again, these are studies that are being evaluated still at this point. What do we need to think about? Clinical care guidelines, again, higher rate of side effects than when used with diuretics or anti-diabetic medications. Lisinopril, the number one medication that I said that was the one that was number one, has serious interactions with 49 different drugs, moderate with 224 drugs, and mild with 168 different drugs. So it's the number one medicine, but it has so many different interactions. So I think that our job, again, is to pay attention. Well, we know that so many patients are using more than one medication at this point, that we have the ability to guide them down the road about what they need to be working with and what they need to be careful of. Too many times that, we find these situations where they're having systemic or ocular side effects from a medicine, but it's because of the combination of the two, as I gave that example earlier. There was a study again that talked about unexplained retinal hemorrhages. Do consider ACE inhibitors. And it may just be that it's allowing too much blood to go through. It's allowing the wall to change up that way. I'm not sure on that one, but there are some studies that were showing those. When in combination with diuretic, consider the diuretic influence, such as transient myopia. We're going to talk a little bit briefly about Topamax, but there was that shift, the myopic shift there. But utilization of the ACE inhibitors with diuretics can cause myopia, as soon as the diuretic's out, if everything gets better. Again, looking at dry eye as being a factor or something you need to be able to manage. I talked about the utilization of one medicine versus another medicine, and we think about, when we use our glaucoma medicines, how they now cause dry eye and anterior segment conditions. And if we try to now use, rather than using, cyclosporin to treat the redness from latanoprost or what, I'm just trying to keep them as generic as possible. Thinking about these preservative-free medications or combination medicines so that we're able to do them lower dosage with less side effects. So just, pay attention to those, what's happening when you're seeing these patients also. All right, number 6. Diabetics. Okay. Basically, there's several different mechanisms here. Some are designed to stimulate the pancreas to produce and release more insulin. Some it's glipizide, glyburide, Januvia, different things like that. Other ones are designed for inhibiting production and release of glucose from the liver. That's metformin. That's the biggie that's out there. Actose is another one. Blocking action of stomach enzymes that break down the carbohydrates. Again, Precose. Again, don't see an awful lot of that being used at this point because the Precose is used for other conditions, other GI and enzyme, gastroenterologic components and management there. Improving the sensitivity to cells to insulin. So again, if the insulin isn't being made or it's making too much or whatever, there's one that makes the cells respond better. That's Actose. That was a big one again a few years back, slowly seeing reduction in that. Inhibiting the reabsorption of glucose into the kidneys. There's Invokana, Jardiance, Farxiga. These are, again, medications that you're seeing. Each of these are different mechanisms for reducing the overall glucose circulating throughout the body. Lower cholesterol have very modest effect in lowering blood glucose. There's well call. So we have patients that are being managed for diabetes by the utilization of cholesterol medicines. But the big ones right now stimulate the release of insulin. And this is your biggies that you see right now: semaglutide, the Ozempic, Wegovy, Rybelsus. Trulicity was the one that was previously to that. That's a different medication. That's Exentide, Victoza, liraglutide. There are different medications that are out there. Those are the non-insulin injectables that are having a way to reduce the actual circulation of glucose throughout the body. And obviously insulin is out there. Okay, so what are we doing? We're controlling blood sugar. There's such a very large variety of medication. Metformin, we're going to concentrate on today because that's the number 4 one. And, there's so many patients out there. Besides being used for diabetes, it's being used for weight control. It's being used for PCOS, polycystic ovary syndrome. There's, patients I've seen them on for headaches. I've seen them, metformin, for in Europe, if you go back again 15, 20 years ago, metformin was the drug of choice. I mean, they were using it for everything over there. It was almost like the panacea medication. The United States is always, we're trying to find other newer and more expensive medications for our patients. So not as much that. That's why we have Wegovy and Ozempic, because metformin just was too cheap. So diabetic medications, let's talk about specifically metformin at this point. So hypoglycemia, well, obviously, if you take enough of it, you're going to get too low at this point. You can get weight gain or weight loss. The goal is to get weight loss, but there can be other things. GI issues are going to be on there. What other things do you need? Again, most of the things that you'll see here are going to be GI, and it's something that I learned. Again, a lot of this, besides through the studies, are clinically that I have patients who are telling me that they are, I say, are you still on your metformin? They're coming back a year or two, after on it. And they say, no, I'm not taking it. I couldn't leave the house. I was getting diarrhea all the time. I was having GI issues all the time. And I'm like, oh, interesting. I didn't realize that until I started doing the research and say, yeah, that is one of the big side effects of metformin is a lot of GI issues. So if you're talking to patients and they're on metformin for whatever reason, but then you also see they're on a GI medication, an antiemetic, something along those lines, and now they have GERD and all kinds of other things. Well, it may actually just be a side effect from the metformin, and feel free to just say, hey, you know what? Why don't you talk to your endocrinologist about this? Why don't you talk to about your PCP? Maybe there's other options by just simply modifying the metformin or stopping the metformin. Please don't ever tell your patient to stop the metformin. Tell your patient to talk to their family doctor or their endocrinologist about it. But talking to them about this is definitely it's a good thing for you to help your own patients and to also treat them, get them better help. What are the possible ocular side effects? Well, blurred vision, cataracts, EOM paresis. Again, that one's a toughie for me. Diplopia, same thing. And the reason I say that is because we know that the blood sugar, the diabetes, can cause all of these things. Which is which. The ocular side effects of uncontrolled diabetes, as it says, are far more common. Okay. So again, study about 7-8 years ago, metformin decreased the odds of both glaucoma and diabetic retinopathy compared to other oral hyperglycemics. So when the study was done, they did not have as many of the injectables out there. So I'm not sure exactly the relationship at this point. I did take a look to see if there was something more recent on there. I did not see anything specifically looking at glaucoma related to the injectables, the semaglutides and things like that. But yeah, obviously reducing the blood sugar is going to reduce the likelihood of diabetic retinopathy. Monitor your diabetics at least yearly, more frequent when complications of diabetes are present. So not a big component there. Big conversation we've talked about. This was from last summer. Came out. There was a study that showed there was an increase in non-arteritic anterior ischemic optic neuropathy with patients that were overweight and type 2 diabetes that were on semaglutide management. All the patients that were included in the study were seen at the same large hospital, and it was an eye hospital, which treats lots of non-arteritic ischemic optic neuropathy. The true question is were these all due to the semaglutide, or were there other systemic components of it. You know, the study, it came out last year. The answer is we still don't know, but there seems to have been some correlation there. So just pay attention. If you have a patient that's coming in with an anion, that they, you know, that you are thinking, is this due to the medication? And if you have a patient that comes in and says, I have sudden loss of vision, think about this being a factor associated with, because you're gonna get the phone call before the patient walks in.
You know, Harvey,
Yeah.
I'm gonna give you a chance to take a breath here.
Thank you.
And talking about non-arteritic anterior ischemic optic neuropathy, it seems like every medicine that comes out has at least one associated case of non-arteritic ischemic optic neuropathy with its use. And I think it's very important that to underscore what you just did say is it is controversial. There have been some small series that have indicated that it may be the semaglutides may be a risk factor. Other studies have shown probably not. But the implications here, you know, this could be a life-saving medicine.
Absolutely.
Same and the erectile dysfunction medicines, they're lifestyle changing medicines. You know, we have to be very cautious about over fearing these patients. You know, these are small numbers of small numbers, and do we want to plant doubts in their mind about what may be a life-saving medicine, or doubts in their mind what might be a lifestyle changing medicine? You know, we need to be very cautious about that, and not just look at the superficial headlines.
I agree with you. I mean, you know, how many patients have you blinded with the use of prednisone, like we were told years ago? You know, it's just, you know, you got to look at the benefits over the risks on a lot of these things. I agree with you.
Harvey, even worse. How about the dilating drops when we
Oh
were
my God,
fighting?
no, exactly. But yeah, that's the point. Joe, I appreciate the comment. You're absolutely correct. And that study was very, very vague in the outcomes on there. So, you know, it was, but you know, somebody had a chance to, you know, they did some, you know, data analysis, and hey, sure, look at that. A lot of these people have that. All right, let's jump on to number 7. Okay. Go here, number 7, the respiratory agents. Your albuterol, your beta 2 adrenergic agonists. There's 2 primary classes we're going to look at within the respiratory agents. The adrenergic agonists and the prednisone are oral or inhaled at that point. Basically, it's for prevention of bronchospasm, COPD, different along those lines. And there's a lot of these out there. Again, patients often forget that the inhalers, as the oral and the nasal inhalers at this point, they often forget to put those on their list of medications because they're either used PRN, or, you know, or they don't, you know, if they're sticking in their nose, it doesn't count. You know, it's the same kind of conversation there. So, you know, need to be aware of these. They do have different effects on them, and they do have different effects systemically as well as ocular. Within the respiratory, specifically on albuterol, because again, albuterol, if we go back there, was number 10. Different components there: increased sweating, dry mouth, leg cramps are another one that we've seen on this. I have not seen tinnitus, however you want to say it, but you know, again, it's listed as one of the options that are considered there. And you know, anxiety. I've seen patients get shaking, and these are the patients that are using this on a daily basis, or even the ones that are using it acutely, but they get this quick response afterwards, and they get this overall just excitement associated with it. So they need to, you know, we need to pay attention to the systemic components that way. Let's talk about the ocular blurred vision. Again, it's causing, in most situations, it's causing an accommodative spasm. It can cause angle closure. Again, this has to do with the pulling of the ciliary body forward in that scenario. You can see pupillary dilation and mydriasis associated with it. Conjunctival redness, eye swelling, eye pain. Now, again, since the majority of these patients are using albuterol on a acute or low dose chronic, it's not that common in my office to see an awful lot of these side effects, but they are out there, and so we need to be aware of it. an interesting study that went in there on this one was also the utilization of Combivent, which is two different, medications in there. And each drug alone had no impact on IOP, but when using in combination, IOP did increase. Now, it's funny, I have more patients call me about this than allergists or PCPs that are giving me the call that says, my doctor prescribed Flonase, my doctor prescribed Combivent, my doctor prescribed whatever it may be, and it says I shouldn't use it if I have glaucoma. And these are primarily their, POAC, primary open-angle glaucoma patients. And the doctor never said a word to them. And even though the doctor knows it, the risk is low. There's no question on it. But anytime I have a patient that calls and asks, I'll say, no problem, come on in. We're going to do an IOP check. We're just going to check it before you start. And then I'll see you back, soon after. It could be a month, it could be 3 months, depending on my risk factor. If the angles are wide open, I'm really not going to be overly concerned on it. But if they're slightly narrow, I may double check them again in 4 to 6 weeks just to see, is there going to be any change in the IOP? You do need to pay attention to those because there are, as I said, a lot of patients that are using these medications out there. Be aware of any inhaled medication use. Monitor steroid use. So again, when you start talking about the medications, Advair, the fluticasone, those types of things, Flonase, those types of medications are going to have systemic side effects, and they're also going to have the increased intraocular pressure side associated with them. So basically, be aware of IOP increases. And again, I have not seen on the albuterol pressure changes or angle closures. The steroid inhalants, I absolutely positively have seen IOP increases, of anywhere from 2 to 4 millimeters of mercury. Again, if it's a patient who's running 15, 16 and wide open, I don't really care that much. But if I have a patient that's a LTG and they bump up, they go from an 11 to 14, that's a concern for me. It obviously would be you. So you may need to reach out to the doctor, the doctor prescribing the medication, and manage that with them also. Oh, look at that. Time to take a break for you. Next question.
All right, let's get this launched.
And
What
Harvey,
class of
while he-
drugs are associated with retinal detachments? Go ahead, Harvey. You can read the A,
You
B,
know
and
what?
C.
Did I change my number? I have a different,
Let
I
me
have a,
close it. Let me see.
yep,
Let me see if I can find it.
I have a different one on here.
All right, here we go. We'll get this one.
Did I do it out of order to you? I'm sorry.
It's all right. We got it.
Thank you.
What class of drugs are not associated with hallucinations?
And Joe, you had a question while people are
Well,
answering?
yeah, one came in, and it's a pretty broad question. I think I
Sure.
know how you'll answer. How quickly we expect to see these side effects from starting medications immediately, or after longer use, or does it vary by medicine?
Of course, I mean, of course, the answer is going to be it varies by medication. Some of them are going to be pretty quick. And if you think about even the topical steroids, patients don't have a pressure spike on day 1. It's usually day 7 to 10. Okay. Now, if you're worried about those types of medications and having the ocular effects, then you have to look at your risk factors on these patients to make the decision on that. We go back to like the opiates, it's going to be longer term utilization before you're going to start to see side effects associated with those also. So the vast majority of them, it's going to be longer term utilization before you do see any side effect. But it can be on shorter ones. And when we talk about epileptics, I'm going to show you an example. We have an example where it was pretty darn really quick, actually.
Now, Harvey, based upon your title, I assume you're not going to spend a lot of time on topiramate. Is that correct?
I am not, but I'm going to address it briefly. Yes.
Okay, because I'll just give the clinical pearl so people are aware. I know you're going to talk about the risk of angle closure and how that happens.
Yep.
But that is one of the immediate side effects. My experience has been, it's usually within the first week, and generally speaking, within the first dose. I do know of a situation where a doctor doubled the dose and caused it to happen. But if that doesn't happen, angle closure within the first month on topiramate, it isn't going to happen.
I would agree with you. And we actually, it's so fun and no funny, haha, is prior to the documentation and the study that went out and it showed this, we actually had 2 different patients who had clinical signs of angle closure, and the primary thing that we saw was the moderate change in refractive status, where they went from a basically a -1 to a -6, and and then that was, we had no idea. The studies on the Topamax was not out at that point, but we ended up contacting the neurologist and getting the modification on that one.
Yeah, interestingly, that usually is the precipitating complaint is the sudden loss of vision, which you can refract them down to. They do get their vision back, and they had a significant significant refractive shift. But until this is all figured out, I mean, Harvey, can you think of how many holes were put in irises that didn't need to be done?
Obviously, it's
Because that doesn't work.
no, that does not in this situation. Yeah, I agree with you. All right, so we ready to go on the questions now?
Yeah.
Greg, what do you got
Well,
there?
I can give you the answer. Here we go.
Please.
It is, let's see, do we have the right one? Which is not. And I have with A, 9%, B, 36%, narcotics, 1%, and your penicillins are the winner at 54%.
Okay, good. This is going to be a good one then. I'm going to go over this one. So let's push my slides number 8. So we're going to go to anti-ulcers. Okay. You're going to see the answers as we come along on that one. I mean, well, I guess I can go back for a second. You guys see my slide here right now, correct?
We do.
Okay. So we're going to see that penicillin, narcotics, and anti-ulcers, all 3 are associated with it. The angiotensin 2s are the ones that are not. And let's go over that. Okay. So the anti-ulcer medications, basically, again, you have your PPIs, your proton pump inhibitors, such as omeprazole, pantoprazole, Nexium, the Prilosec, different things like that, versus your histamine 2 receptor antagonists, Tagamet, Zantac, Pepcid, those types of medications there. They are treatment, the utilization is for GERD, heartburn, different things along those lines. And number 6 was the omeprazole of the number 6 was the utilization of all medications across the board. Systemic side effects, the histamine 2 receptor antagonists. Again, what do you see on those patients? Difficulty breathing, confusion, wheezing. Again, it's a histamine 2 receptor. So you got to remember, it's not going to just simply work on the GI. It's going to work everywhere. So they need to be, you're going to see a lot of the systemic side effects there. On the protein pump inhibitors, if that one goes right to the GI system, again, it has to do with how each of these systemic medications are going to have an effect on the body and the way it's working out that way. Looking at the ocular side effects, histamine 2 receptor antagonists, you get changes in vision, they complain, or red irritated eyes. I will say flat out, I don't know the mechanism on the red irritated eyes. It's in the research. I have never seen a patient who had red eyes from these types of medications, other than possibly from dryness. But it's out there. On the other hand, the PPIs, I have seen patients that do have red irritated eyes. It talks about dry ocular irritation, things along those lines. There are documentations of anterior ischemic optic neuropathy and optic atrophy. Luckily, I have not seen those. And, it's funny. We talk about things that we haven't seen. Joe and Greg know my wife, Maria, for years and years, and know that she sees low vision patients. So we get the funkiest of the funky stuff that comes into this office. Patients that have, there's only 3 of them in the country, and we happen to see 1 or 2 of them because they were referred in for low vision service. They got these things. I see more, and we're not going to talk about hydroxychloroquine, but I've seen more Plaquenil toxicity than most retinal doctors have, just because they're being referred here after they've already been diagnosed. That being said, I've not seen any PPI optic atrophies, but we're going to skip over that one because this really, it just showed no ocular aspects here. But this is what I wanted to talk about. So Charles-Bonnet syndrome, again, a study that came back about 7 years ago. It's been reevaluated again at this point. It shows that there was an increased aspect of hallucinations with patients who have wet AMD and are on a PPI. Okay. Charles-Bonnet syndrome, patients are talking about seeing things. These are visual hallucinations, no question at all at this point. Many times they start off as very happy hallucinations. I'm seeing flowers, I'm seeing horses, I'm seeing, X, Y, and Z. And then they often turn ugly to the patient, to the point where the patient is actually now being treated with antipsychotics, different kinds of medications, because of the interaction of the Charles-Bonnet syndrome. Many times in these situations, now because the studies are out, patients are being told to avoid the PPIs. It wasn't that way for years, but still we see these patients that they're coming in, and when we go down, Maria's asking the question, she's doing the lifestyle question, and they're asking about hallucinations and depression and things like this. And these wet AMD patients, whether they're on PPI or not, are talking about having these mild hallucinations. If they are on them, and if they do have them and they're on a PPI, Maria will immediately just say, here's a note, we're taking this, we're sending this to your doctor. We need to get you off this medication. There's too high of a risk for it. So why do I bring it up? We talked before about the links of hallucinations with anti-ulcer medications. This is a big one, and is one that we really have a direct impact on in helping the patients out.
Hey,
Luckily-
hey, Harvey, let me chat to the audience a little about Charles-Bonnet, and you can definitely feed into it and give yourself a break there. Is that Charles-Bonnet, for the audiences out there, because I have a really great case and a video of someone with Charles-Bonnet that I like to play. And what I found out is, even though we talk about a lot, unless you're doing low vision, because that's where you see it, the one eye has to be the best corrected eye is 2200 or usually worse. And what happens is these are hallucinations are called release hallucinations. I think they come from the temporal lobe where images are stored. And it's because the eye can't give the brain what it wants. So the temporal lobe says, hey, I'll help you out, and we'll just release them. The key between that and maybe psychosis, Joe might know the proper word for that, is that they never talk. These are images of maybe cars or pine trees or boyfriends or girlfriends in the past. So these get released, and that's what Charles-Bonnet syndrome is. The low vision, like Harvey and Maria, they know it all the time because they see it. But my point to that is, if you ever see someone that comes in, it's 2200 in their better eye, maybe say to them, in one of my clinical pearls is, hey, are you seeing things being released? Are you seeing things that they're not talking, so on and so forth? And a lot of times they'll go, oh my gosh, doc, how did you know? I didn't want to bring it up. So a lot of times they don't bring it up because they think they might be going crazy or loopy over this. So make sure you bring it up when that happens. And my final point, Harvey, is I'm not sure if you'll talk about it, but I've seen this in the literature, and one of the side effects with the antiviral medications too. But what Harvey's talking about and what I'm talking about is they don't have 2200 vision or worse. These are people with good vision having this Charles-Bonnet-like syndrome.
Yep.
Harvey, it's all yours.
No, you did. I liked exactly what you said. It's again, I have the aspect of seeing them, and these are visually impaired patients at this point. And many times it's the family member that's saying, mom's talking about this and mom's talking about that. And I have I haven't heard the phrase that you made reference to with the non-verbal. What how did you say there was a word you had said there about the
Yeah, the image is they just don't speak.
okay,
They're
got
not.
it. Okay.
Yeah, so when they see them, they
Yep.
don't have a conversation with these people. Like I have a
Correct.
video of a person
Yep.
where they see their dad all the time, but she says he never speaks.
Correct. Yeah, and I said the one that we see. I mean, again, we must have happy patients. Most of them, they're seeing flowers on the wall. They love the wallpaper. Okay, and the wallpaper's moving, and it's that kind of a conversation. But yes, I don't have they don't have communication aspects on it, so that's the extent of it. I was not going to go into the antivirals, but I have seen that aspect there also on the patients using the antivirals. Again, my experience on the antivirals and I will tell you, I've only seen one who had a Charles Bonnet with an antiviral. But they were on a very, very high dose. So I mean, I don't know.
Same
Go ahead.
thing with me. One patient, she had bilateral cornea transplants for zoster.
Yep.
And she couldn't have been more than 90 pounds wet. Maybe with some cement shoes on, and they had her on 1,000 milligrams 3 times a day of Valtrex, and she had these Charles Bonnet syndrome. And I get what they were doing; they're trying to prevent it from having to go through more
Yeah.
corneal transplants. But we slowly weaned her down to a lower dose, and these hallucinations went away.
Yeah. We treated at CBS, but let somebody else. We had a corneal specialist dealing with the other stuff, so I understand that one. All right. So again, just keep in mind that these can interact with other medications when you're out there, and that have a requirement on there. Let's look at number 9, anti-epileptics. All right. So in here, your Dilantin, Neurontin, or gabapentin is number 13. That's why we have that in there. Here's your Topamax, Lamictal, your broad spectrum versus narrow spectrum components. It's used for seizures, pain, trigeminal neuralgia, headaches. And I think that that's a big one. Is we see a lot of the broad spectrums being used for patients who have headaches, migraines and chronic headaches. I've seen an increase in those medications also with long COVID. We're seeing patients that are complaining of the brain fog, and they're being put on these medications, which in my mind cause increased brain fog, but it does help with the reduction of the headaches. So just want to pay attention to what you're looking at this point. So some of them work on the sodium channels, some work on calcium channels, some work on the GABA transport system. Basically, there's a lot of different, it's a wide variety of drugs used for other things other than seizures, but their initial approval was for anti-epilepsy. The systemic side effects, again, the angioedema, the swelling of the eyes, the sleepiness, again, another component there. Suicidal ideations you need to pay attention to. Hair growth, how happy do you want to have a patient being that you're treating with a headache and they start now growing hair on their face? And again, these are often, a lot of these medications are being used in women for these other conditions we were talking about. I'll go back to here. So ocular side effects. Now, amblyopia was listed. I cannot figure out how amblyopia is listed on here because my understanding, I'm a COVD fellow, amblyopia, you don't develop amblyopia, but it was in there. Diplopia, I definitely have seen patients that have developed diplopia on these types of medications, more on the broad spectrum than the focal. Simply again on the aspect that they just get this so fatigued, so tired, and so out of it, they can't converge. And it develops sometimes. I'll actually see some intermittent alternating exotropes or intermittent monocular exotropes will happen. Nystagmus is seen patients again on higher dosage where they start developing nystagmus, ocular motor dysfunction. Again, these are I'm primarily seeing pursuit eye movement dysfunctions as opposed to saccades. Basically, they just can't maintain the fixation. And this is, again, why is this important when we talk to the cops, when we ask them to do HGN and they can't follow the darn target? You got to look, maybe they're taking gabapentin because they have peripheral neuropathy from trigeminal, from herpetic lesion. They've got back pain, something like that, and you're starting to see issues. Increased IOP can be in there. Again, there are studies that there are research out there that shows cortical lens opacities. I've never seen one, but again, it's out there. So if you do start to see these things, you need to think about what is going to be causing the eye findings you look at. So some of this, again, there's a ton of different studies that are out there, basically showing, a Sabril. And again, I think that may have been taken off the market, or it's actually been rarely used at this point because there were field loss signs there, ERG changes. It just had all kinds of visual issues that were just terrible, and patients were having issues. So they stopped using it at this point.
It definitely has a black box warning. I think that's the big thing that happened with it.
Yeah. Gabapentin, again, that's the big one. Neurontin, if patients, mild neurotoxic effects, again, What are we talking about with that one? It is primarily the aspects of the somnolence, the fatigue and things along those lines, just the spaciness that goes on there. Tegretol, abnormal color perception, reduced contrast sensitivity. You know, we do test contrast sensitivity in our patients. I have not seen a change on that, but I have seen color perception. And again, it's not that they don't pass a color vision test, but they're telling us their colors are distorted. And it's kind of fun because we'll play with wavelength specific filters, your old Corning lenses, or I don't want to mention brand names, but there's other lenses that are out there that have color changing on them. And patients will notice a major change when they use these lenses. It's nothing we're prescribing, but it's kind of neat to see these patients on Tegretol. And in those scenarios, what are we doing? Telling the family doctor, telling the neurologist, whoever's taking care of it, the headache, the pain management, that, you know what, this person's having a side effect. We need to consider changing into a different medication. I have never, I can probably say never. I've never had a doctor tell me no, that they won't change it. In pretty much, I can't think of a single time they've ever done on any of these medications. I never tell them I want you to change it, but I often will say there's a side effect that is a known side effect. I think, could you consider other options, is what I traditionally say.
The
There
only
are,
time I've ever had a doc where it was questionable, and it's not in this group of category, is amiodarone. It can create corneal
yeah,
whorls,
yep,
and it can cause vision loss
yep,
because of the irregular stigmatism, because the arrhythmia is so bad.
yep,
But I've had them switch, and so we're taught that the amiodarone doesn't cause problems, but it does cause problems.
sure it does.
It can cause vision loss, but that's the only time where I agree, Harvey. Even all your list here so far, they've all been willing to change to another category, but
Yep.
that's the only time where maybe 2 or 3 patients, they were just so brittle they couldn't do it.
Really, there was no other option on the AFib medicines, the arrhythmia medicines. Interesting.
Yeah, I mean there were, but they were like, geez, by the time it gets off of them and the half-life, and we try, the arrhythmia was so bad that
Yeah.
they just couldn't do it. So, and I was
Uh,
just working with a cardiologist, and they get it. And this cardiologist actually runs around now telling everyone, "Hey, look, this can cause vision loss." It's all he lectures too, so he uses some of my topographies for that. But just a handful. That's the only one I can think of. So I agree
yeah,
with you.
that's an interesting one. I both hands up. Never refer one out for amyloidone toxicity that was not already off of it. Again, I've seen them once they've had the toxicity, had the whirls, but they've already been taken off the medication at that point. So I haven't had the chance to do that one. Okay, so there we said we said we weren't going to talk much about it, but here's the conversation as Joe and I were talking about before. The Topamax, basically acute myopia, secondary angle closure. The primary one, as Joe brought up before, is, and I said it and then he confirmed it, is the patient comes in, they're put on the medication, and within a week, doc, my glasses I can't see. And you take a look at them and you refract them, and they've got 3-4 plus diopters of myopia shift at that point, and many times the IOPs are increased also, and it's just a mess. Luckily, stopping the medication really fixes the problem, and it goes really quickly, goes back to where it needs to be. So anti-epileptic medications can have an impact on ocular structures. We talked about beware of the neuro-ophthalmic side effects when evaluating symptoms in patients. Again, you got to think about the way these medications are working, is that they're going to be impacting the neurologic system, and you can get field losses. You can get ocular motor dysfunctions because of these medications. And many times modification of the medication can completely eliminate it, or at least dramatically reduce the components. Because many times, Joe talked about, the lifestyle medications before, and the risk of non-arteritic ischemic optic neuropathy. If you have a patient who's had migraines every single day for the last, 12 years, and they found a medicine that's finally working for them, it's tough to tell them to not take that just because they can't do convergence. Now they have a convergence insufficiency. So just, think about those things when you're there. All right, number 10. Okay, I wrote this. You're out of order. That's because I did not go in the order that was on the top 20. I jumped ahead because number 10, actually, we're going to mix with later on into a different section. So I want to go on to thyroid medications. Levothyroxine is the number 2 prescribed medication that's out there. It's a thyroid hormone replacement used for hypothyroid conditions, congenital, acquired, or surgical. Side effects, weight loss is a biggie. Heart palpitations, angina. Again, the heart issue seems to be a big factor that I see an awful lot of our patients. Actually, there's a typographical, it's myocardial infarction as opposed to infraction. And the aspect is, again, I've seen cardiac issues associated with these medications. The funny haha again, is that, the lack of the medications also can cause a lot of cardiac issues also. So you need to be aware of that. Side effects, ptosis, diplopia, ophthalmoplegia. This person obviously has Graves. That's not, it's not, your medication is not going to cause Graves. It's going to go the other direction. It can cause pseudotumor. And I've had a patient who was on, it wasn't levothyroxine, it was one of the synthetics. And they actually started with this myasthenia-like symptoms, where basically at the end of the day, their lids were drooping and they were developing a diplopia. We worked them up for myasthenia because we swore that was the problem, and it actually came back that it was due to the medication. So again, just things to pay attention to. You're thinking one thing, everything looks one way, but when the tests come back, you got to think of a different direction. So what do we consider on this one? Suggestion that topical beta blockers can impact thyroid medication. It's been discussed out there. Basically what that's saying is if you're using, timolol, that it can impact the thyroid medication. That was something that was talked about years ago. Not really something that we have heard recently, but again, this is old school thoughts. And be aware that incorrect doses of thyroid medication could induce symptoms that do hypothyroid or Graves' disease. The normal dosage, and I actually ask my patients, it's funny, there's certain medications that I absolutely want to know in the chart, what is their dosage, okay? If you talk about, we're going to talk about like Benicar in a little bit. I don't care if they're taking 20 milligrams or 40 milligrams, okay? Because the dosage on that doesn't make a difference. The levothyroxine, it goes from 25 micrograms. I've never seen anybody over 200. Most of my patients are somewhere between 50, and it says 75, but most of my patients are between 50 and 112 micrograms. And I think that a lot of that has to do with the fact that doctors are paying more attention to this. It's important to know, because if they start to take more and more, you're going to get these aspects of hyperthyroidism as opposed to hypothyroid. So when they start pushing in more and more and more, it becomes problematic. So something to pay attention to your patient. So I double check that. I always know how much metformin the patient's on. Those are the two that I primarily pay attention to. I check on everybody, but those ones I make sure every single time, because you'd be amazed at how quickly those medications will change. Number 11, your calcium antagonists, basically calcium channel blockers. Amlodipine, Norvasc is your big one that's at that point. Rapamil is again an older one that's out there, and Cardizem is something you also will see. In this one, it inhibits a transmembrane influx of calcium ions. Basically, again, we talked before about getting the blood supply going, getting the blood through those vessels as quickly as possible, as easy as possible. It reduces peripheral vascular resistance and therefore reduces blood pressure. So there's different mechanisms to change these, to affect blood pressure. There's two different types that you're going to be looking at. In this scenario, one is a more potent vasodilator, treat hypertension and stable angina. Little or no negative effect upon the cardiac contraction or conduction. That being said, some of them are less potent vasodilators, but have a greater depressive effect on the cardiac conduction. So if you have a patient that luckily, this is not something that we are going to be having addressing as far as prescribing or monitoring an awful lot of in the ocular components of it. But it does have an impact on the visual and ocular side effects that we're going to see based on how this electricity and cardiovascular changes go. So we're going to come back. I'm going to address that a little bit in a moment here. So the systemic side effects, again, you're going to look for, I see a lot of these patients have the headaches and the dizziness. I think those are the big ones that I've seen on our end. I don't see as much on the GI. I mean, it's listed on there. I have seen a couple of the patients with the flushing where they're actually just getting this red face, these red cheeks, red throat, things along those lines. And many times, which is good, is because it's on the face and neck, the patient notices it and they're calling the primary care physician or the cardiologist and saying, this is what's going on. Our family member notices it, and they will actually be able to change it pretty quickly. And back to the question about how quickly on those things, those usually happen for me when I've had these patients in the office. It's usually within that first month that they're getting these, and we're talking usually within the first couple of weeks. Leg swelling, again, the question is it causing the blood supply to go there? Or is it just not allowing the blood supply to come back in there? Okay, diplopia. I threw this in here because we have had a couple patients who did come in with diplopia with a calcium antagonist. And in that scenario, we were lucky because the patient came in, they had just started the medication within the previous month. Whenever a person comes in, no matter what the condition is, you know, one of the first, what is different? What have you done differently? I've done nothing differently. It's all the same. Did you start any new medicines? Well, I did start this medicine at last month. That's that last month, 2 months ago, that's the clue. And in this situation, we had the patient that came in, did talk about diplopia. They actually developed I think it was just a decompensated fourth is what ended up happening on that person. And they just started the medication. We called the doctor. I said, look, I don't know. We don't have anything else. We did run a scan on the patient just to be on the safe side. Everything came back negative. We called we wrote the letter and touched base with the cardiologist, and they changed it and got, changed the medicine, and things kind of settled down. Do I know that was truly the answer? I don't, but that was the only thing that we saw that we stopped the thing and it made a difference there. Okay, so calcium channel blockers are associated with increase of primary open glaucoma, requiring a procedure. Procedure being SLT is the conversation there. I can, again, that's the numbers that are out there, the studies. I have not seen patients getting an increased risk of POAG. I guess I'd ask Joe or Greg, do you guys see amlodipine patients having a higher risk for glaucoma?
I don't think I do.
I just haven't seen it, so that's why I'm asking. It's there, but the same, it's funny. That's the study. The same study suggests a strong protective association within SSRIs, which we talked about before, with primary open-angle glaucoma. So it was a study that came out there, and you got to take the studies. Today oxygen's good for you. Tomorrow oxygen won't be good for you. You got to think about where these studies come out with and what they're coming up with. Calcium antagonist, cyclosporin interaction, but no study out there with ocular cyclosporin, the Restasis and all the other ones that are out there at this point. It can increase levels of calcium antagonists, interacts with statins. So as they're taking it, you may pay attention to cholesterol levels if they are taking a statin, because a statin is not going to work as well. These patients already know, don't take grapefruit. Everybody says, oh, I can't eat grapefruit. I can't eat grapefruit. Okay, well then, if somebody says that at your breakfast and you're traveling, know that they're on some CAI component there. Number 12.
Actually, before you go too far, a question did come in
Please.
about how does vasovagal syncope relate to calcium channel blockers?
How does it react?
How does it relate to it? Have you seen that?
I have not seen it. I mean, the aspect is, again, if we go back to here, I'm going back to this slide here. it's letting the blood supply go through the vessels at an easier rate. It's going to have an impact on your vascular smooth muscle. I have not seen a direct relationship with vasovagal. They're two different systems. So
Yeah, I would think that perhaps when you have a syncope, it's just is a syncope
yes,
due to low blood pressure.
which yes, I would agree with that. And maybe that was where the question was, and I just misunderstood it. But yeah, I mean, we do said that the dizziness is this drowsiness. We will. If they become hypotensive, they'll get a syncope type of effect, but it's not necessarily a vasovagal type of response. So, but that's a good thought, Joe. I would second that one.
Yeah,
sorry.
that's more neurologic with the
Yeah.
vaga, being stimulated. This is not stimulating that nerve, so I think you're okay. So
That's a good question. I'll write it down and I'll see if I can figure something out. If I find something, I'll go back to it. All right. So your DMARDs, your your antirheumatics. In this scenario, basically DMARD, disease modifying antirheumatic drugs. These are medications that are not treating, and it's a big conversation I've had with other docs. These do not treat rheumatoid arthritis or other inflammatory conditions. Basically, they are modifying the way the patient lives their life is basically it. It doesn't treat it, but it does. It says it slows the damage to the joints. It induces and maintains remission. It reduces frequency of flare-ups and allows tapering with steroids. Think of it as glaucoma management, okay? Because we don't cure glaucoma. We slow the progression. We reduce the inflammation. We reduce the likelihood of getting lost there. And that's what these drugs do. What are the ones that are traditionals that we look at? Methotrexate, Plaquenil, azasan, different things along those lines. Celsep is out there for rheumatoid arthritis. Cytoxin, again, I'm just looking at lupus ones, other ones that are available. And these are different medications that do have an impact on these inflammatory conditions that you're going to see in your office. And these are ones, again, we're not going to talk about hydroxychloroquine. We already said that. But these are ones that you can see eye-related issue. Let's talk about the systemic ones. The problem is that some of these, specifically in Xeljanz, you're going to be looking, Xeljanz is the big one that they're using for rheumatoid arthritis. So you're going to look at these patients and you're going to see these crumpled up hands, these crinkly hands, and very uncomfortable. It's been a while since I've seen a patient who's been complaining about their arthritis because there's so many medications are out there. These DMARDs are out there that have made it so the patients are more comfortable. I'm starting to see, for some reason or another, even patients that are on these medications having greater discomfort and greater progression of their condition, even on the medications. So what are the systemic side effects? The low blood cell count, the anemia is a big one. That we have seen on these patients. And again, that's why you talk about on the biologics, the monoclonal antibodies, that seems to be a big factor here, is seeing a lot of the patients developing anemia in those patients there, bruising easily, bone marrow suppression. Again, these are conditions because these medications are non-steroidal and they're not non-steroidal anti-inflammatories and they're not steroidal anti-inflammatories, but they basically reduce the inflammation that's going into the joints and the cartilage and the tissues there at this point. I have seen a couple patients that have developed liver damage. They've developed hepatitis along the way. Just so that you need to be aware of these things. You're going to pay attention to these patients. So here's a picture. This is not an amyroidome patient, but you can get vertex keratopathy from some of these medications, kind of how you were talking about before, Greg. Side effects, yes, I've seen conjunctivitis. They are, and use conjunctivitis. We're not talking about bacterial conjunctivitis. These are patients that just have this overall glassy red eye, pink eye. Okay. I was seeing these patients on these medications. Again, they're more often on the Rituxan, on the biologics as opposed to the traditional DMARDs. Again, because of them, these reduced ERG amplitudes, that's, you know, the hydroxychloroquine, also methotrexate. I currently, this moment, do not have an ERG, but I do know that they are very effective for checking for retinal function with a lot of these medications in there, because you do see retinal toxicity. We've seen the toxicity component of it in the office. You know, but you do need to pay attention to these types of things. Why is this? Because again, these patients are going to come in, but they're going to be unhappy. They're going to be they're not healthy patients to start with under most circumstances. You know, patient comes in and says they have blurred vision photophobia, possibly some, you know, you'll see some mild conjunctivitis, and then you see, oh, by the way, I'm arthritic. Well, your first thought process is going to most likely be anterior uveitis. Okay. And you take a look and it says infectious uveitis, but that's a different conversation. Eye pain, you know, you look at the conversation that are listed in there, and you're going to be looking for cells, you're going to be looking for pupillary responses, things like this, and they're not going to have it. But the medication is what is actually causing the problem, as opposed to the condition, the treatment. Excuse me, the treatment is causing the problem more so than the disease itself. So you need to be attention to those things. On the methotrexate, the periorbital edema, blurred vision, conjunctivitis, that was the one I said. We see a fair number of methotrexate patients in our office at this point. We still see plenty of Plaquenil patients. We still get I'm grateful. We still have rheumatologists that are referring over for Plaquenil evaluations. They we do the evaluations and manage them accordingly. So. Clinical care, basically, the entire class can have serious ocular side effects. You know, it went back to, we'll go back to here. Again, the non-arteritic ischemic optic neuropathy, uveitis, things along those lines. Retina issues is the big issue there. And in that scenario, you need to be able to make clinical decisions quickly and positively. I do not have an ERG. At this moment, we're getting another one in the future. But I think that would definitely be something to consider if you're seeing a lot of patients that are using these types of medications, because it is definitely a much more specific test than potentially visual fields and even our OCT for picking up early signs. We've talked about this. Look for it. It says, 20% of childhood onset lupus has corneal vortex keratopathy. Now, how are you going to know that? You're probably not. The patient's going to come in. They're going to potentially have the corneal vortex, the full corneal the keratopathy noted, and you didn't know that they had child onset lupus. You're going to have to try and figure those things out. They may have had some inflammatory condition or ended up not knowing it and just had low symptomology and were treated here and there over the course of time. Again, the key part there is communicate with the physician providing their care. Number 13 goes here. Hormonal contraceptives, classes, there's estrogen, progesterone, and combination ones. If you don't know what these are for yet, we're all in big trouble. I crossed out that last part, postmenopausal keratoconjunctivitis sicca symptoms reduction. That was, I am going to make a positive statement as far as COPE reviewer picked up on something I put in here. There was a study. Do I have it? Yes. Okay, good. I want to make sure I have the study here. We'll come back to that study in a second. So common side effects, headaches, mood changes, decreased libido, weight gain. Obviously, we know that you can get pseudotumor in these situations also. But ocular side effects, corneal thickening. Why is that important? A lot of these patients are women, obviously, and they're wearing contact lenses. And when you're doing things, corneal edema, corneal thickening, those types of things, it can have an impact on the way the patient's going to be wearing their contact lenses, the way the lenses feel, the way the lenses are prescribed. You may be changing powers because of these things, not trying to figure it out, not being able to figure it out. Looking for 6 nerve palsies, hemianopia. I have seen, again, I saw field loss. I've never seen a hemi from hormonal contraceptives, but we have seen that retrobulbar neuritis. I've seen that papillary edema. I've seen those aspects also. Intraocular hemorrhages. Again, a lot of these things we've seen over the course of time. You look at the condition and you go, what the heck is going on here? Why do I see, microaneurysms? or, macular edema. Like what the heck is going on here? And then you got to look back and say, okay, well, she's a young woman, she's this, that, and the other thing. You run your blood work and nothing else goes on there. Consider that the problem may be the contraceptive that's going on there. Okay. So there was a study, again, it's about 7-8 years ago, talked about the utilization of estrogen seemed to reduce the symptoms of KCECA. They seem to exhibit projective effects against glaucoma. And also they had antioxidant and protective actions against AMD. Now, I brought this up, and the reason I crossed it out, because that was in your deck, but I put the line through there. And the reason I did that is the reviewer took a look at this, looked at the study a little bit differently than I did, and found that this was strictly it was a finding that showed that the utilization of the estrogen seemed to do all of these things, but it was nowhere did they make recommendations for treatment. So when I had in my thing up here, it talks about for treatment, it was making reference to menopausal keratoconjunctivitis and KCECA. I made a global leap, and I made a mistake on that. So I'm just giving you the heads up. So when you take a look at the deck here, the answer is yes, estrogens can reduce these systems, can be protective against glaucoma, but it is nowhere that there's any documentation that says that you should prescribe these or the patient should use those things to prevent to reduce for KCECA. Advise against smoking, consider roles with other symptoms. Number 14, angiotensin 2, ARBs, at this point, same conversation, allows the blood vessels to relax, to dilate, lowers the blood pressure, easier for the heart to get through. The blood to flow through there. I'm going to go through these. Number 12, Cozar, losartan is the one that's out there. Avapro is a big one. Benacar, that's my drug of choice that I take. And in this scenario, the side effects, again, very similar to every other of the antihypertensive medications that we talked about before. Dizziness, headaches, nausea, the GI things. And you need to be aware that, again, it's the medication is causing these side effects. And the doctor who asked the question before about, and we'll just take it from vasovagal to just say syncope, all of these medications are going to cause are very likely going to cause some type of syncope effect. Simply on that aspect is its goal is to reduce the blood pressure. The blood pressure is too low. If the blood pressure gets too low, then guess what? They're going to have these scenarios of lightheadedness and dizziness and things like that. What are the side effects with these? Temporary blindness. There was a couple studies that showed that the biggest one is blurred vision. It's just an overall blur. And sometimes it's dry eye. Sometimes you can treat them with medications on that. Sometimes you can't. And these are patients that they're going from 2020 or 2015 to 2025. They're not going 2050. It's just this general blur that they're having. And again, in that scenario, you have to talk to the doctor and say, you know what, I'm not sure. And that's why I'm scratching my head at this point. I'm not sure. Is this a side effect of the medication? I'm not sure. Okay. But you do need to pay attention to it. And you need to say, maybe this is something that you have to consider with this. So oral losartan, again, this is the big one, measured blood pressure, heart, IOP, things like that, and pupil diameter. Remember I said before that all these studies, they did check pupillary responses there. In this one, there was no changes in heart rate or pupil, but it did significantly reduce IOP in all subjects, okay? Blood pressure dropped in the hypertensive patients. So how this works is, they're saying it's not mediated by blood pressure, but rather specific role re-angiotensin system that is going to have the impact on reduction of IOP. We are not prescribing losartan for IOP, but earlier I had talked about the utilization of beta blockers and the relationship to IOP, and how I said the studies didn't support it after all. Here's one that showed that it did, not beta blockers do, but ARBs do. So be aware of the possible impact on IOP. If a patient's on one, you may be getting lower readings because of the medication, and or if you're seeing a reduction and you're treating a patient and you're treating them for glaucoma and all of a sudden their pressures go down a lot, it may not be the medication you're using, because we consider that. Consider the patients with dry eyes and monitor for vision at that aspect. Okay, what, Joe, Greg, you have this one up or no?
Well, I'll tell you what, Harvey, why don't you, we have 3 minutes.
Okay.
I know you're not gonna get through the slide deck, so
Okay.
why don't you, we don't have to do we don't have to do the presentation or
Good.
the
Let,
poll.
us jump to this one because this one is an important one then, okay? Because this gets to another question. Is that okay?
Yep, that's what I want you to do. Pick
Perfect,
how
okay.
you want to wrap her up, and this is
Perfect,
where you
got
want to go with it.
You got it. So penicillin, basically, it's a big one there. Why do I bring this in here? There's a lot of systemic side effects, ocular side effects, side effects. You get C. diff from it, but I'm going to jump here. Visual hallucinations. So penicillin, besides the yellowing eye, because the liver issues, blurry vision, visual hallucinations. So before I had a question up there that talked about different things. So we went through already we talked about the PPIs, the proton pump inhibitors. We talked about narcotics, and penicillin. Those are your choices at this point, and that's why I wanted to have this in there. The the angiotensin 2 medications. There's nothing out there that causes the visual hallucination that was in any studies. Why is this important? Again, Joe talked about patients before with hallucinations. Greg talked about the patients before with hallucinations. And, we do write penicillins. We write amoxicillin. We write Augmentin. If a patient starts talking about visual hallucinations, again, it's usually over the longer term, but you do need to be aware if they have that. I'm going to jump ahead because these are really irrelevant on that one. Let me jump to the last bit because I know these were the things that people wanted to know about. Okay. How do I properly code for encounters due to systemic medication complications? Procedures don't change. These are evaluation and management services, or they're general ophthalmologic services. Just because you prescribe a medicine, you shouldn't be necessarily upcharging. It is what you're doing, whether you're prescribing a medication or you're prescribing a pair of glasses or contact lenses. The aspect is the risk does change. So in the new E&M guidelines, as prescribing a systemic medication or changing or making a recommendation to a cardiologist or a rheumatologist to change a medication, that does increase the risk factor and can bump up the risk component on your E&M calculation. So you maybe want to take a look at that. Don't forget what you are doing is diagnosis what you found, not what they have. So retinal toxicity, corneal toxicity, dry eye are what we're treating. We're not treating rheumatoid arthritis. We're not treating arrhythmia. We are treating the eye condition that we have, and that's what you're supposed to be documenting. Now, yes, if you have a patient, and I'm not, if you have a patient on Plaquenil and you're doing a visual field or an OCT or an ERG, yes, you should be putting down your Z79.899, your long-term use of medication, plus the disease itself, but it's the condition you're finding there. And then look at it if you should code also any systemic diseases. I've mentioned this at least 4 dozen times. Communicate with the other patient provider. It is so important to have that time and ability to communicate with these other doctors. Joe talked about before, he shares information with other doctors. Greg talked about how he did also. It is so important to have the ability to take what you are finding and show the other doctor how you are helping the patient. It does, yes, it's great development of your practice, but you know what? That patient is going to be so overwhelmed and so appreciative because no other doctor is taking care of them as well as you are. And they truly, truly appreciate that. So share your information, send your field, send your recommendations, write the note, just let them know, you know what, I have a concern that this patient's dry eye is because of X, Y, and Z. I'm treating their dry eye, but I think this may be a consideration. Is there any opportunity to change those? And, sometimes the doctors are going to just, ignore. Most of the time they'll try and do something if it's chronic management, if they have the ability to do so. Just be careful. That's all I got to say about that. And I guess this is time for questions.
We're good. We didn't have anything new roll in, so you're good.
Okay, good. I'm glad to hear it. I guess I gave enough information there. People were bored. They fell asleep already.
No,
Well,
I
I
think
don't think they did that.
I don't think at all. So let me just say this real quick while while we have a little bit of a discussion here, Harvey, is that everyone out there, if you look at your screen, you'll see that little red dot. If you want to start that survey, please go right ahead and start that survey. You don't have to wait till 9:30 for that link to come through. Harvey, a few things. I have a complications lecture, and I love the way you delivered this tonight. I've certainly learned a few things and probably have to add and tweak a few things in the lecture. But 55% of Americans take an asystemic medication. And then on top of it, you add the polypharmacy to it, that many are taking multiple medications. I work in a population where in a week's time, I might not get a patient not taking a medication. So I found this, the most commonly prescribed classes of medication and their ocular side effects to be a great resource, a great review, and it will help me in patient care when I get there tomorrow. So thank you.
My pleasure. And as I said, it's interesting your comment about the you don't go a week without. I mean, I don't go a week without. There's no question. I mean, I don't go a day without where there's somebody who doesn't come with it. Because again, so many kids like that. They're all on ADHD meds, anxiety meds, whatever it is at this point. GERD meds. It's crazy at this point. I skipped over there was one section. You guys can go back to the slides that talks about vitamins and supplements. And there's obviously an awful lot of information that's out there on that. You may want to take a look at those issues. And a lot of them are taking medicines or supplements because of attentional issues and, sleep issues. And they do have an awful lot of impact on ocular findings also. So.
Yeah, we can always bring you around for a round two. So, Joe, any other questions in the chat box?
All good.
Good.
Everybody just thank you for your presentation.
Yep,
Pleasure.
you're getting the virtual thank you, Harvey. I appreciate you doing this. The questions have been answered. This was the most commonly prescribed classes of medications and their ocular side effects beyond steroids and hydroxychloroquine. So with that being said, Harvey, thank you for doing this. I know it's
Thank
a
you very
lot of
much.
work to put these together to get them approved. And thanks for being a part of our national webinar series. That will conclude the education.
Thank you, Harvey.
You got it. Bye-bye, guys.